And so who are you needing to argue with about which?
The wrangling is really to a couple, like, so we have Joe Capella, Scherer, and then Carmen Lewis, and a few other people here, she's like the clinician. Who's on the place. And there's there's this tension between what is interesting, like clinically interesting, what is, something we can imagine actually giving to patients sort of in a practical sense.
Yeah.
Versus testing or scientific questions and making decisions about what to show people for like pragmatic, we're gonna do a study to test something from this.
Okay.
Later, we're gonna figure out like what we can roll out.
Okay.
So, yeah, but so there's a little bit of a basic science versus pragmatic D&I going on here, and it's not like at this point in the study, they're not converging. Those are two different threads are converging.
Well, you've introduced not you, but you've introduced this problem of there being this mismatch in the guidelines, right? So
yeah, I mean,
so your basic science is now not pragmatic.
So what?
Like you can't do basic science pragmatically anymore because they don't match what we used to.
Yeah. Well, because we can still try.
Yeah,
Yeah.
that's fair.
Well, but by trying to set harms and
Right.
therefore no harms.
Exactly. Exactly.
So it could be decided that way, except.
We just need to choose a couple of things. Yeah, we can do big studies, but not one study for you guys.
Yeah.
Hey, team.
Everybody's here.
Yeah.
We've got everybody in from the hallway at least, so we'll go ahead and get started. Can everyone on Zoom hear me? I want to make sure that we not having audio issues today. Jordan, any complaints so far? I see some thumbs up. Great, we're gonna go. So welcome everyone. I'm Sarah Brewer. I direct our education program at Accords. I want to welcome you all to today's seminar. For those of you who are not familiar or maybe need a refresher, what is Accords? Accords is supported by the University of Colorado School of Medicine and Children's Hospital, Colorado. It's a unique one-stop shop for faculty to conduct pragmatic research, receive various types of services and supports for grants and projects, along with incredible mentorship training and education in health services research. So you can see a few of the major things that we do at Accords up here. And I specifically want to highlight our methodological cores and programs. And today, our Colorado program for patient-centered decisions. I got it right this time, which is partnered this year with putting on a shared decision-making series.
The right arrow.
There we go. A few upcoming Accords education events I want to highlight before we get into things today. First is CopperCon, or the Colorado Pragmatic Research and Health Conference. This year's theme is Innovations in Pragmatic Research Methods, from Data to Equity, Policy, and Sustainability. It will be June 5th and 6th, and registration is open there at coppercon.com, and we hope to see many of you there. Before I introduce our speakers, just a couple of housekeeping items. First, if you are on Zoom, please use the chat or to share any questions or comments you have throughout. We'll be monitoring that, and we will have some time at the end of the hour for some Q&A. And then second, we hope that you all take a minute to complete an evaluation. If you're here in the room, those are sitting right outside as usual. And if you are online, you'll see those in the chat as we get closer to the end of the hour. All right. Today's seminar is the final in our Ethics Challenges and Messy Decisions and Shared Decision-Making series. And we welcome Dr. Chris Knoepke and Laura Scherer. Chris is an assistant professor in the Division of Cardiology, where he studies shared decision-making in the cardiology, equity and evaluation for advanced heart failure therapies and gun violence prevention. Dr. Scherer received a PhD in social psychology from Washington University in St. Louis and completed postdoctoral fellowship at the University of Michigan Center for Bioethics and Social Sciences in Medicine in Ann Arbor, and the Ann Arbor VA, sorry. She was an assistant professor in the University of Missouri Department of Psychology before moving here in 2018 to pursue a focus on medical decision-making research. Her research lies at the intersection of behavioral science, decision-making, and medicine, seeks to understand patient preferences, healthcare seeking versus avoidance, and how to facilitate shared decision-making and improve communication between doctors and patients. Join me in welcoming Dr. Knoepke and Dr. Scherer.
And I appreciate the opportunity to speak with all of you today, although I think I know virtually everybody in the room. I assume that there are some other folks online who much of this will be new to. This is an exciting and fun project that Laura led from, let's see, what, like 2019 moving forward. And it's sort of only relatively recently sort of come to its full fruition, but really the goal of the entire project is to streamline and make more available and more implementable clinician-facing training about shared decision-making specifically, such that it can be more broadly used. Basic conflict of interest. I have a bunch of funding, and so does Dr. Scherer. We don't think that there are any conflicts inherent in any of these. The work that we're talking about here today was supported by art. Sorry. No, it's all right. There's a recording in progress. Looking ahead to the rest of the talk, but what we're going to do here is we're going to talk about overview of shared decision making and the Scherer approach model, which was designed by ARC in its first iteration, and what we iteratively designed and reconceptualized a bit over the course of this project, as well as evaluating it and the vision for the future. So, as the topic of this whole series has been, shared decision making, as many of you know, we really think about it as a meeting of experts, where the clinician is the expert in medicine, in treatments, in the experience of other patients and care partners. And the patient and their care partners are experts in themselves, their values, their preferences, and their experience in life. And what we want to do is to facilitate sort of multilateral communication around all of the types of decisions that people are facing in healthcare. So both the big kinds of decisions that we typically talk about in our group, so whether to get an LVAD, whether to get an ICD, those kinds of things, all the way down to which statin do you want to take, or whether you're going to get breast cancer screening when you're 41 years old or not. All of the kinds of things that should be at the heart of patient-centered care. Now, shared decision making could be viewed as a sort of like functional and structural conversational skills, which I in one of our qualitative projects was referred to as sort of a laundry basket of these skills, allowing clinicians not to have to carry all the individual socks of good communication and patient-centered care. So you could think that a clinician who's just sort of good at communicating is going to be good at this, and they may be at sort of an advantage in acquiring the skills and implementing them in practice. But there are a set of skills that clinicians would need to use in order to actively or to effectively engage in order to most effectively sort of do shared decision making. And McCool and Clayman lay these out nicely in their systematic review of shared decision making related articles way back in 2006. And these discrete elements, we're putting it up here. There have been more recent reviews of shared decision making, but these were the ones that informed ARC's original conceptualization of the Scherer model and approach. So they include things like, in the course of the communication between the clinician and the patient, the clinician, they identify what the problem is, the options that are available. They discuss the pros and cons or risks and benefits associated with each. They elicit the values and preferences of patients and others who are weighing in on the decision. They discuss with the patient the ability and their self-efficacy to follow through with these plans, checking for understanding of all of these elements, as well as explicitly making a decision and making plans to follow through with it. So each of these, I don't know why this keeps doing it. It's probably because I made Jordan use my computer instead of his, and I apologize. But So each of these things are discrete activities that should be considered within sort of an ideal shared decision-making encounter. Now, a lot of times when we talk about shared decision-making, we sort of tend to talk about the use of decision aids. And that's an incomplete conceptualization, but shared decision-making is often done using the support of high-quality tools, between patients, care partners, and healthcare professionals. And we have a ton of experience locally, of course, with many of these types of tools in developing, evaluating them, including ones for, again, primary prevention ICD, LVAD, implantation, whether to consider hospice, aortic valve replacements, firearm access when there's someone in the home at risk of suicide or who has dementia or things like that. And there's hosts of other discrete decision aids. And we've learned a lot about how these tools get used, and quite a bit about how having them impacts processes and clinical processes and patient-centric outcomes. These are limited, however, to those discrete decisions. And we think that, and ARC also believes that the bigger, broader goal is to train clinicians to consistently deploy these kinds of skills and processes in everyday care decisions, including those that don't necessarily have high quality decision aids available. So here I want to sort of acknowledge that we're operating with a couple of core beliefs, many of which are backed by reviews and other science, but one of those is that shared decision-making improves patient care, both in terms of patient experience and other meaningful clinical outcomes. Another is that shared decision-making is not routinely implemented, even among many clinicians who believe that they consistently do so. And we also believe that the best shared decision-making is the decision-making that will actually occur. And by extension, the best shared decision-making training is the training that people will actually attend and that will actually get implemented into practice. And on that note, we know that shared decision-making isn't always practiced effectively. So substantial evidence highlights that clinicians often speak too quickly, use jargon, interrupt patients. There was one study that's cited pretty often that the average time that a patient is allowed to talk is somewhere between 12 and 15 seconds before they get interrupted by a clinical provider. Which isn't great when you ask somebody what's important to them, and they might need to take a second to reflect on that, sort of situate themselves within the options that they have. But even thinking about options, healthcare professionals don't always effectively communicate that there are options or that there are decisions to be made. Even when they believe that they've done so, often if you ask patients after the fact, which decisions did you make? How many decisions did you make? You'll see that healthcare professionals will say, well, we decided, we identified this is a decision, this is a decision, this is a decision. We went through all of these and we came to them. And then if you ask the patient, they'll say, no, the doctor just told me what to do. And so identifying those and undermining that mismatch becomes pretty important. And we also know that the explicit elicitation of patients' values, goals, and preferences doesn't always happen totally effectively. And ARC is of the belief, and we are of the belief too, that lack of support and training for clinicians as part of either basic clinical training or for advanced practitioners and the availability of that training is an important barrier to overcoming this. And so in 2014, ARC developed the Scherer approach model, which has these 5 elements based on McCool and claim and systematic review. And it teaches clinicians these 5 sort of essential elements of shared decision-making. So the S stands for seek your patient's participation. So actively ask them to be part of the decision-making process. H is for help your patient explore and compare treatment options, which is a nice way of sort of combining all of the, let's highlight what are the pros, what are the cons of each. Let's help you understand those. Help me realize that you understand what we're talking about so that we can make it work for you. Assess your patient's values and preferences, reaching a decision, and then evaluating that decision as you move forward. It's also, the Scherer approach is the only freely available generalized shared decision-making clinician training program, which then also was designed to meet the needs of not just a specific discipline, but clinicians in general. And so the process of this, so at least the early stages of the project that we're talking about here, were about first kind of understanding what people, what clinicians, patients, other stakeholders would feel about the Scherer version that came out in 2014, which we're calling the Scherer Approach 1.0, and then to adapt it in such a way that it might be more implementable, and then evaluate that. So in the course of this, I just want to give you a sense of where the Scherer approach was when we started. So it included 8 hours of training, which in a train the trainer model. So for those who might know what a train the trainer model is, the idea is to provide training to the people who then we're going to go out into the world and disseminate that on your own. So they tend to be sort of a highly there's a highly intense upfront process of training people to be both trainers and to understand the content of it, but then also training them in the material that they would then presumably take out into the rest of the world. But this 8 hour of training had additional fact sheets, in-clinic posters, video examples, organizational readiness assessments, and 4 modules, each of which had their own reference guide. And the 4 modules in the 8 hour trainings included a combined total of 212 slides. So you're already seeing, like, one of the criticisms that we got very early on was that this was a lot, and this wasn't something that busy healthcare professionals would be able to do in sort of their routine care. So I gave you a little bit of a segue there. So overall, the feedback on the Scherer Approach 1.0 was that clinicians and patients agreed that the curriculum was important and useful, and that the training information was generally good and positive, but it was too long for implementation in busy clinical settings. And their main recommendations for improvement included rearranging content such that highly valuable content would be seen up front and not duplicated. Deleting or trimming down sort of the overall amount of content, even beyond taking out duplicative stuff, and then rewording or reworking content to emphasize key points in a shorter training, and with a eye toward making it practical. So, in the things that we changed in the course of developing Scherer 2.0. And I know that I'm bouncing around a little bit and we're sort of underselling the process that we undertook to get to this point, but we have some material on that later if you're curious to hear about it at the end. But the original curriculum, again, consisted of 5 modules, including a training module for that was the train the trainer emphasis. And after the reviewer input suggesting cuts and based on the results of the literature suggesting that a substantially shorter time would be helpful for training, the content was reduced to 3 modules, including dropping the trainer's module entirely, as the Scherer approach would no longer be implemented using this model, but instead a direct clinician training module which would be supported by a facilitator guide. I'm sorry, I'm going to click through and get to that, which you can already see sort of follows sort of a flipped classroom sort of model where there would be sort of video modules that we created highlighting sort of the most valuable content and what the folks who participated in the early evaluation said was important. Followed up by a facilitator guide to highlight the in-person activities that would be sort of done at the individual practice level. All right, so the valuation of the Scherer Approach 2.0, which Laura is going to come up and talk about in a little bit. There's this red box here that shows you that there's something important coming. So be ready for that. This is we called this a type 2 implementation effectiveness trial, where we implemented the Scherer approach in 8 primary care and 4 cardiology practices located across Colorado, and using a pre-post design evaluated Scherer's effectiveness. But the red box is to highlight that we are going to focus here on implementation outcomes using the REAIM framework, because again, remember that the best shared decision-making training is the one that's going to get used. So we're going to highlight the implementation outcomes as we assess them. Most folks in here, I'm sure, are familiar with REAIM domains, but just in case, we're focusing here primarily on REACH adoption and implementation. And I do want to highlight that REACH is typically viewed as a patient-level outcome, and the change here is that the Scherer approach is intended for clinicians. So REACH is going to be framed as a clinician construct. And now I'll kick it over to Lauren. Yeah. Might have moved a little faster than I did.
No, that's great. Here. Yes, I can. All right, I get to talk about the fun part, which is the data. I mean, that was really fun, Chris, thank you,
Yeah,
but
that's
but data is always my favorite part of every project. So I'm going to tell you a little bit about what we found with regard to implementation. Yes, that worked. Okay, so first, focusing on adoption. Did we have practices across Colorado actually agree to do this 4-hour training? Remember, it was an 8-hour training, now it's 4 hours. So we thought there was a better chance for adoption. With our primary care practices, we got 71% adoption. We contacted 14 primary care practices from across Colorado. 10 of them agreed and 10 of them completed the training in all aspects of the evaluation. We also intended to recruit 4 cardiology practices. That didn't actually happen. And in fact, of the 10 cardiology practices that we contacted to participate, only 3 agreed to participate and only 2 of those completed the training and all aspects of the evaluation. So we had much poorer adoption among cardiology practices. So here are the practice types and some of their characteristics. So as you can see, we had practice sizes that were large, medium, small. We were going to cities, west, east. We had rural practices as well. We had federally qualified health centers as well as independent family and health system practices. So we had a lot of diversity in the practices that we recruited. So what was going on with cardiology practice adoption? They gave us some the non-participating cardiology practices gave us some feedback and reasons why they didn't want to participate. One of the number one reasons is that they would still, despite the fact that we cut the training time in half, they said 4 hours is too much of our time. They also questioned the value of shared decision-making training and how to identify patients for shared decision-making. And this aspect of people's resistance to wanting to participate in this was a little bit frustrating because one of the things that we taught people as part of the shared training was how to identify participants for shared decision-making. But apparently I wasn't effective at making that case at the outset of recruiting the practices. Cardiology practices also had some unique logistics that they were grappling with. So cardiology practices often had staff that were spread across multiple sites. They had staff that were going to different locations, and it was really hard to figure out how to train everybody and how to do the evaluation. So there was this logical issue that we encountered that prevented us from being able to recruit as many cardiology practices. And then there were the mundane reasons like, we don't have bandwidth right now, it's not a good time, we're short-staffed, and all those other things that weren't necessarily a part of, due to Scherer itself, but rather to the circumstances. Primary care practices, we only had, a few people not adopt who were approached. We got no responses from 2 of them. One of them said no bandwidth, and another one questioned the value and how to identify patients for shared decision-making, so consistent with what the cardiology practices were saying as well. Okay, so now I'm going to move on to REACH. And of course, REACH was defined as a physician-level construct for the sake of this study. We received, the way that we evaluated REACH was a little bit sort of indirect. So we had 176 email contacts from practice leadership. And this included all of the staff that practice leaders thought could benefit from the Scherer training. And of those, the total clinical staff were 146 people. And then one practice invited 7 patients to their Scherer training. So we thought that was an interesting REACH outcome, that they wanted to include some of their patients. They had a panel of patients that they often used as ways to evaluate their practice, and they wanted those patients to be involved. So out of those 176 staff that were invited to the training, we had 82.9% attendance to the training. So 146 people attended. And of the 146 clinical staff who were invited, we distributed 129 CME certificates. So we had 88.3% REACH among the clinical staff. So that's how we evaluated REACH. Okay, moving on to implementation. One of the things that maybe wasn't highlighted as much at the outset is that we had two different training modes, or training delivery modes. We allowed people to do this training in person or as a webinar if they felt like a webinar was easier to schedule. But one of the things that we found is that most of these practices wanted the in-person training. They wanted somebody to come physically to their practice, gather with them, and present the training to them. 9 of the practices selected in person. Only 3 selected the webinar, and only 1 webinar actually worked pretty well. And 2 were maybe not a disaster, that's too strong a word, but they really were problematic. So there was low participation in all the discussion aspects of Scherer. People had their videos turned off. It was hard to do some of the activities because of the way people were spread around. Some people were, 10 clinicians in a room together with the rest of them dispersed around the state or the country or, in their city. So it's hard to do, 2-person interactive discussions. Okay, we also allowed practices to choose either 1 4-hour training block or 2 2-hour sessions. And the reason for that is we wanted to encourage adoption and make this feel more feasible to practices. And we had equal numbers choose the 1 single training block versus 2 2-hour sessions. And so what that said to us is that the 2 2-hour sessions made it easier for some of the practices, but other practices really wanted to get it all done at once. And we actually had one of those single training blocks end in just 2.5 hours. So it seemed a lot more efficient also to do just 1 single training block. And that wasn't because the discussions were shorter. Our trainer told us it seemed to be that everything was just facilitated by not having to reintroduce everybody, reintroduce Scherer, go over the things that were discussed last time and all those things that make 2 sessions a little bit more time consuming. But then again, the 2-hour sessions were easier to schedule for us and for them. We also had 2 major training adaptations to report. We had a video that was supposed to demonstrate, poor shared decision-making, and then the second half of the video was good shared decision-making. And in general, the clinicians really hated this video. They felt the topic, which was urinary incontinence, was irrelevant to their practice. They thought it was too basic, it was corny, and it elicited just these very critical discussions. And so the trainer came to us early on and said, can I please stop showing this video and instead have a discussion about some shared decision-making scenario that the group comes up with themselves. And we said, of course, yes, we don't, want you to force you to keep doing something that is, ineffective, if not, negatively impacting the training. So we took the video out and replaced it with a discussion about a practice-relevant shared decision-making scenario of their choosing. And then the other adaptation was actually kind of a little bit more interesting. There was a final action plan activity where the practice was supposed to develop an action plan for how they would implement shared decision-making at their practice. So, for example, selecting 1 or 2 decision aids that they might try to use that they might use regularly in their practice, or creating some kind of a plan for making this happen on a regular basis. But by the end of the training, participants really didn't feel ready to do that at all. And what they wanted was to explore decision aids more. They wanted to see examples of decision aids. They wanted to walk through them. And so the trainer came to us and said, hey, can I stop doing this really ineffective action plan and instead do what these people seem to be wanting me to do, which is to show them decision aids? And we said, sure, that sounds great. Why don't you, show them common decision aids? So statin choice came up a lot as a decision aid of relevance for these practices. Okay, we also had a few observations from field notes before I let Chris take the stage again and tell you about what we did with all this implementation data. The practices generally communicated that they saw value in the training, which is great. So we had one quote, this team realized the benefit of the training even at a cost of 4 hours of their time. So that's great. We had some more experienced practices though, and they felt the training was pretty basic. And those practices though, despite feeling like the training was probably too basic for them, liked the interactive elements and really found value mostly in the interactive discussions and activities. And then we also found, and I mentioned this before, the webinars just lacked engagement. So our trainer wrote things like, I was the only one on camera. Not one of the staff spoke during the training. This is despite, questions that are supposed to elicit discussion. Only the 3 providers when called on, so that's not good at all. Okay, so re-aim results summary. Again, we focused on adoption, reach and implementation here. It was really difficult to recruit cardiology practices. Some questioned the value of shared decision-making training and struggled with logistics and the time required. We did see pretty high rates of clinician participation when we recruited the practice, so that was good. In general, in-person trainings were preferred. The webinars, I just would not repeat. I simply wouldn't do it again. Breaking up the training into smaller blocks seemed to facilitate the ability for some practices to participate. And while Scherer felt valuable to some practices, it was too basic for others. Also, just a slide from a survey that we did to demonstrate that clinicians did like the Scherer training. So we asked them if they had a positive evaluation of it. 91% said yes. 75% agreed or strongly agreed that it was useful for their daily practice. Most said that their experience of using Scherer in their daily practice was positive, and 93% said it helped overcome some shared decision-making barriers for them. And with that, we will go to next steps, which include how can we improve the Scherer approach based on these implementation findings, and how can we increase the likelihood that the Scherer approach is adopted in the future? And Chris will do that part.
Okay. Well, so thank you so much, but think about where this leaves us, right? So the people who participated in it said that they liked the training. They said that they found the content valuable. They also said, and that accords with sort of the global view on shared decision-making, is if we ask any healthcare professional anywhere if shared decision-making is a good thing, they say, yes, absolutely. And I do it, and I do it very well. But then what they also said was, some of it was too basic, and we really like the interactive components of it. And then they also didn't participate in many of the interactive components of it. And also that we know that even if people say that these communication skills are too basic, if you put it out into the rest of the world and you studied how people actually behave, generally speaking, they probably aren't doing it. So we were left with this sort of tension of practices are saying that that the basic material is too basic and they don't need it, and yet we know that they do. And ARC, in very specific terms, wants to support the dissemination of the basic material in addition to the more advanced skills, while at the same time wanting to honor and listen to their feedback that the interactive components where they would get to look at materials that are more specific to the kinds of conversations that they're having with patients in their practice and in their communities, and the types of skills that their clinicians need wanted to be a focus, right? So they wanted that ability to tailor, and also that despite being half as long as it was before, it was still too long and difficult to schedule, sorry.
Money to fly a trainer.
And it costs money to fly a trainer around, and it's difficult to. I mean, you can't put Robin in a copier and copy her over and over again, which is one of those sort of universal implementation challenges, right? So in the next set of Scherer approach training materials, we tried to address all of these sort of all at the same time. One of them was ditching entirely the idea that there would be a dedicated trainer, right? So instead of having the dedicated trainer who would go to the practices and facilitate this whole thing, it was reconfigured such that there would be videos and materials, and then the facilitation guide wasn't for the facilitator who was a professional facilitator. It was for whoever in the practice was going to be the person who was leading the conversation, and that I think that we can logically think that a lot of times that would be sort of like a practice manager or a senior professional, but it could be anybody. But it had to lay out in very specific terms the kinds of things. What questions do you want to ask? What kinds of things do you want to make sure get discussed? And what questions or issues should you anticipate from the folks who you're leading these conversations with? We also did some more revision of the Scherer, what we ended up calling the Scherer approach 3.0 of the curriculum itself. So as you can see, this follows a very sort of flipped classroom sort of approach, where in the orange here, we standardized the didactic presentation. There was quite a bit of editing that went along with covering, instead of having first 5 modules, then 4 modules, now it was 3 modules. One addressing, sort of the overview of shared decision making, then the use of patient decision aids, and then communication challenges. And then the green highlighting the discussion elements that would be associated with each module, which they could do, again, sort of thinking about sort of flexibility and delivery, either as like, one module for one lunch hour, one module for another lunch hour, one module for a third lunch hour, or, if you wanted to schedule it all at once, then you can go ahead and do that. But the green activities would be discussion and interactive elements that would align with the topics within each of those 3 modules. So again, and these, I got a little bit ahead of myself. So the 3 modules, again, the first one was shared decision making and the Scherer approach. So outlining what those 5 elements of the Scherer approach are. The second was using identify decision aids, what they are and how to use them. So helping practitioners learn where to find them, how to sort of subjectively assess their quality and their utility, as well as then how to use them in their communication with patients. And then the third module being communication barriers and solutions. So, and that was mostly Dan, and a lot of really great material on both numeracy and then sort of the challenges that we've seen in the trials of some of our decision aids here, including my personal favorite, which is when patients ask the doctor or nurse or whoever, what if it were you, or what if I was your mom, or what if I was your dad, and the varying approaches to how to address that question. And then each of the activities here we laid out in detail, including making a patient-centered recommendation. So there's often this tension that we hear in the discussion amongst trainees, where they feel like if you're doing good shared decision making, you're not making a recommendation, which isn't really true, right? You're sort of neglecting your half of the shared decision making equation if you're not providing your thoughts and your feedback on the patient and what their circumstances are. There was role plays associated with just sort of doing the communication skills, exploring decision aids, what makes communication difficult, including numeracy, and then implementation focused discussion. So what could this look like in our practice? What things should we anticipate as being barriers, and what specific decision aids, if any, do we want to have on hand to support these conversations? So the overall vision for this, and I'm glad that we left some time for discussion and questions, is that the evidence for the Scherer approach in all of its iterations has been encouraging. People generally thought that the content was good and that it was necessary, although there were differences, I think, in sort of what people thought was valuable versus what the intention from the outset sort of needed to be. There's interest in the Scherer approach, in this sort of this design of talking about these types of skills within the clinical encounter. And as an overarching thing, I think we want to support ARC's efforts in disseminating the Scherer approach training and materials across clinical specialties and primary care practices, and in all sorts of clinical populations, age groups, et cetera. And so then I said we have quite a bit more material that we could put up here, and I would look at Laura to do a lot of that. But thank you very much, and we're open for questions.
You don't need to use the mic.
Oh, yeah, and we'll repeat them if we need to.
Excellent room miking.
Okay. So I could hear that really clearly. Yeah.
I could start off with questions just to kind of get people going.
Please.
As an observer and a participant in this project, I want to just commend you guys. That was a really nice summary of a difficult project that occurred through the pandemic. But I guess just one question, and you know less about this, but Laura, this was owned by ARC and working with ARC. And maybe you could just talk a little bit on that, because I think for me, I think when you went to write this grant, I think I even discouraged it, said, oh, the Scherer training is so useless. We shouldn't do that. And then I'm so glad you didn't take that advice, because it's been such an opportunity, and it's because working with ARC gives us a dissemination pathway. But I wonder if you could just talk through some of the challenges of designing something, wow, there's this other group that's kind of a big gorilla invested in it.
Yeah, and maybe we would clarify too that this was a contract, not a grant. So we were working for them, not necessarily for ourselves and our own, research or investigator initiated research. So the call was to, update Scherer and then to implement it. And we knew that we would get feedback along the lines of make this shorter, because it's so long. And it was very academic as well. There was a lot about patient-reported outcomes and teaching people about what is a patient-reported outcome, and, how do you measure them, and a lot of that kind of stuff. And sure enough, when we got evaluations from patients and physicians, so we did a bunch of qualitative. We got a bunch of feedback from them. They said, it's too long. What are these patient-reported outcomes? This is so academic. What's the practical advice? The physicians really want like very practically oriented training. And so that was our focus really in revising this thing. And then we were also pretty convinced that if we did a trainer model, like when is the trainer ever gonna have time to go to the practice? And then what are they gonna tell people when they go to the practice and train them to do this thing? So we were pretty convinced that we also needed to directly train them in practice. So that's where all those changes came from. Make it shorter, make it more practical, train people directly, but you're never gonna see an effect thing. And it was easier to convince ARC, who, that we worked with a person who was in part behind the development of the shared approach. It was easier to convince them about the changes that we, ultimately made when we had the data to support those changes. We had people saying, this is good, but.
And then I think as a general comment with that too, like this group and your leadership in particular was was the right group to be doing that with ARC, right? Because we're used to looking at tools and trainings and educational materials, whether they're decision aids or whatever else, through the lens of pragmatism and practicality and actually getting it into practice. It's very easy. It's not very easy. It's easier, I think, for largely academic people to think if we build it, they will come, and we'll create a wonderful, comprehensive 8-hour training that really does accomplish a lot of goals, but that as a practical matter isn't ever going to be used because it's just too much. And then being able to gather that feedback in a systematic way, and then navigate the relationship with the people who created it originally, in tactfully giving them that feedback and providing operational suggestions that can be taken forward.
I was just gonna say, they turned out to be a super partner too.
Yep.
They were actually flexible and very receptive to be.
They really were, but I think I was nervous about that. They turned out to be great.
I have a question about your Scherer 3.0, and removing the sort of expert trainer from the equation. How did you think about sort of ensuring quality in that training and sort of what those skills really look like as people come out of a training, where it's almost a self-training model where the practices are training themselves. And have you thought about that piece? What does that look like? Does it matter, or do you think about this shared decision-making skills as sort of simple enough?
We really should have a test at the end.
So I'm just curious how you're thinking about that, and
it would be cool to have a test at the end so that the practices will see what they've gained, or how much of the knowledge we had intended to impart upon them they actually gained from the training. I will say that even with a skilled trainer, we had a sort of side part of the implementation, which was something we called shared learning calls, where the practice leads would come together to discuss problems with doing shared decision making, like we thought of the training, discussing different, problematic issues related to shared decision-making. One of the things that we learned early on from one of those calls is that they did not necessarily understand what shared decision-making was even after the skilled trainer had trained them. So, I mean, I think and that was something we tried to address with the revision, some of the lack of clarity about things like the difference between motivated interviewing and shared decision. Were things that we did in a revision in response to that observation, but still, I think people could come out of any training not having much. Whether it's conducted by a skilled trainer or someone who's more self-guided.
Well, and then you mentioned knowledge, but the difference between having gained that knowledge and actually then changing behavior and using it in an effective way are sort of those downstream pieces.
So we have that's the shared 3.0. We can get an opportunity. Somebody ought to give us some money.
And then we have a question on.
There was one more in the room, so I saw your hand.
As you said, that's 7 patients who write into me.
Yeah.
What was the feedback from the patients?
So yeah, the patients thought it was pretty valuable. They actually really generally liked it. I don't recall any negative feedback from them per se. This was very advanced practice that had a lot of patient engagement, as you can imagine, because they had a patient panel that was already there before we came. This was one of the practices that thought the training was a little basic for them, which makes sense as well. But I think my memory of the data is that patients liked it quite a bit. Yeah, great question.
We have a question online from Mary Politi. I found it interesting that they really wanted content relevant to cardiology specifically. I find that when I do these trainings, that making it too specific to their area means they focus on the content of the decision and process of shared decision making or engagement. Did you notice that cardiology examples meant they focused on agreeing or disagreeing with pros and cons, or were they really able to focus on the shared decision making process?
So I do want to offer a clarification, which is that the examples that Chris was giving of that were cardiology related weren't necessarily in training. So the training has pretty broad examples. So for example, the video that was demonstrating shared decision making was about urinary incontinence. Of course, totally relevant for everyday care that cardiologists are giving. So we did have we tried to make this a general training that could be personalized. I hope that helps to answer your question, Mary, and it is a good one. So for example, we had a role play activity where we gave people a number of scenarios, like example scenarios that they could play through as a shared decision-making discussion. And some of those were different cardiology examples, and some of them were more geared towards primary care. But then we said, and you can select your own if there's something that you'd like to practice doing shared decision making with that has come up in your practice that you find interesting. So we did try to focus on the process of shared decision making rather than focus people on one particular topic. And there was one discussion that they had early on that replaced the video that had to be focused on. Their range was pretty. I hope that answers the question.
No, and I think that to things that we weren't able to evaluate in Share 3.0, if there's discussions that are happening, per the outline, in practices that are going through the training, and they're looking at decision aids that are specific to their patient population, I can imagine that that's part of the process, right? Like I could see an interventional cardiology practice finding our TAVR decision aid and really picking apart like whether we're talking about lower intermediate risk patients in the decision aid. Dan and I, we've been on conversations about that recently. And really getting into it and then thinking like, oh, I don't know if I want to use this thing because this isn't representative of my patient. That's a good conversation to have because at least then they're engaging with the idea of how or when they would use it. At least in my mind, I think that it might not necessarily encourage them to use that, but at least they're thinking like, if I were to, what I would have to do is that. Yes. Yeah.
Seem to look like for my patients.
Yeah.
Another thing that we did try to emphasize was shared decision making outside of the context of the decision aid. So we have a decision aid module where we said, decisions are just all you need. We started it off with all you need for shared decision making is you and a patient. But then there are also decision aids that can help. So kind of throughout, we're trying to emphasize that shared decision making is something that is a communication approach and is not dependent on a particular decision aid.
Yeah, that's a lot of point, interestingly. I'm wondering, and you guys have kind of addressed this question through all of the previous responses, but could you walk us through a little bit more of your kind of process of prioritizing? When you get to that sticky point of like, people are saying that they already have these communication skills or they already implement these skills in their practice, but then the data shows that those are actually your primary goals in educating them. Are there like resources that you leaned into, or how did you prioritize I guess your redirection strategies as you were developing Shared Theory? Does that make sense?
I think so. So I think what your question that you're asking, how did you, continue to, or keep that part that is necessary, that like sort of boring Scherer 101
Right,
that we know people need, but they don't necessarily feel like they need,
right,
right? I think one of the big things we did is we created these video modules. So we knew we couldn't throw that material out completely because it's so fundamental. But the fundamental stuff is also relatively boring and it didn't feel as beneficial. And so then we took all of the discussions and activities and things that could be facilitated by a person at the practice, and we use those to reinforce the learnings from the videos. So each one of those activities and discussions is reinforcing learnings in a way that feels more valuable. We're hoping at least feels more valuable to the, more advanced practices, and hopefully everybody's getting benefit. Yeah.
Can I just jump in and add on?
Yeah,
Give Chris a
absolutely.
compliment, because I think Chris, in our ICD work, Chris had the idea of when we go and implement and teach to the sites, let's not teach them didactics, let's just ask them what's hard. And it was brilliant in that it created this discussion because it acknowledged that you already knew this. And then it let them sort of open up this conversation. I was always nervous about this when Chris would do this, but it always worked with all the sites we did it. It would open up a discussion, and so we kind of took that in some of our slides and didn't come in with like, you don't know this, so we're gonna teach you. We came in with this sort of framing of, we know you're doing this, and we know you know it's hard. Your life is really hard. And we kind of use that framing a little bit to just kind of meet them where they're at and say, but there's still some tools, maybe some tidbits, and try to meet them. And I think being a social worker in training, he talks about fishbowl training for communication in his master's program, which I think is not something that clinicians get, but just feedback on your communication. I think that you brought some of that.
Yeah.
I think that is another way of.
Well, you're very kind. I appreciate the comment. But I think the other thing that we did in some of those areas, I remember, and it was in the script where we would say things like, you might not be have a hard time with understanding this, but we've seen, and there's data to show that, nationally, this isn't something that's done very well. So let's go over this really quickly. And and then additionally, it was in the video modules, which let's be honest, they could watch at 2.5 times speed, right? And so if they're getting it at some level, that's better than nothing. But we're also building a structure around here's something that you can digest as you're going to, and then there's this follow-up that'll be happening with your colleagues.
Thank you both for a wonderful summary of how you not just do the shared decision, but how we get clinicians the skills and hopefully behaviors to do the shared decision making in their real world settings. Thank you.
Thank you.
Do you think that made it a learning? That where you said, oh, there's a red box or something important coming? And I just totally focused on that. One way to engage an audience. This red box.
Oh, you see this over here?
Really important.
But I'm not gonna show it to you yet. You gotta listen.
Gotta get there.
That's a good.
It was, in truth, it was